Good evening and welcome to our webinar, Should I Get Pancreatic Cancer Screening? The topics that will be covered tonight are paramount to our community. Our community and the experts who treat us rely on guidelines to help inform medical decisions. These guidelines only happen because of research. That is why FORCE has a strong commitment to promoting treatment, prevention, and genetics research studies that are relevant to people with inherited mutations in order to assure better options for ourselves and future generations. My name is Elise Boucher. I'm a member of the FORCE community, and I will be your moderator. FORCE improves the lives of millions of individuals and families facing hereditary breast, ovarian, pancreatic, prostate, colorectal, and endometrial cancers. Our community includes people with a BRCA, ATM, PALB2, CHEK2, and other inherited gene mutations, and those diagnosed with Lynch syndrome. We accomplish the FORCE mission through our education, support, advocacy, and research efforts. Visit our website for expert-reviewed information and access to our support programs, including virtual Zoom meetings, our peer navigation matching program, and our online message boards. At this time, we would like to recognize our sponsors for making this programming possible and for their continued support of FORCE and the hereditary cancer community. Our presenter tonight is Dr. Ravi Sharaf. Dr. Sharaf is a gastroenterologist and health services researcher with a clinical focus on the care of patients and hereditary cancer syndromes. He is a director of clinical care genetics at Weill Cornell Medicine and an associate professor of medicine with appointments in the Division of Gastroenterology and Hepatology, Department of Medicine, as well as the Department of Population Health Sciences. After his presentation, we will conduct a Q&A to answer the many questions that you've sent us. We will do our best to address each one. Dr. Sharaf will not be providing medical advice this evening. Please reach out to your doctor if you have any specific or urgent questions. I'm handing it over to you, Dr. Sharaf.
Thanks so much, Elise. It's such a pleasure to be here today. I'm such a fan of FORCE and of Sue Friedman, and I'm here to certainly be a resource for the organization and for patients. Thanks for the intro. I think I'll skip over that part of my talk, but these are my disclosures, my conflicts. And so my work is funded by the NCI, by PCORI, and the Gordon and Betty Moore Foundation. I am an investigator on a local trial we have going on at Cornell for a multi-cancer early detection test called GRAIL, but I have no financial stake in that company, and I have no other industry conflicts to disclose. Now let's see if this advances. There we go. So the outline, so this is what we're going to talk about today. So we'll go through some disclaimers. I'll just bottom line it straight up front. I think that's probably the best way to get to the meat of the presentation. We'll talk about pancreatic cancer stage and survival, who is at risk, modalities of screening, and then other considerations, and happy to take questions and comments at the end. All right, so disclaimers. And so to be honest, I think this entire lecture could be disclaimers, but I think these set the stage for the nuances in the discussion today. I'll be as transparent as I can. There's a lot of stuff I know, and there's a lot of stuff that I don't, but I'll tell you where my limitations are. First thing is that there's no randomized controlled trial data, which ultimately is the gold standard of evidence. I'll give you the best data that is available. And the guidelines change every 6 months. So inevitably in a lecture like this, what you're going to hear is opinion, and you're going to hear mine too. My opinion is my opinion. It doesn't necessarily reflect the thoughts of FORCE or Weill Cornell. Elise was saying, I try not to give specific patient advice on talks like this, though I hope that some of the things that I do say are applicable to the community. I think they will be. Everything we do is risk benefits. And there's always unintended consequences. So over screening, incidental lesions, false positives, anxiety, it's kind of how this works. There are variations of care in the US, and I don't think that's surprising to anybody. Different insurances, different coverage policies, different expertise, academic versus community differences. That is our healthcare system, and I don't have an answer for the disparities that those differences confer. One other thing to note is perspective. I think it is important to think about whose perspective a medical recommendation is coming from. So what's done in the US is, and in clinical practice guidelines, a lot of it is from a population health perspective. And important to note that what is of ultimate benefit on the population level may not be what's most advantageous for the individual. So I want to be transparent about that. And then last couple of disclaimers. Interestingly, like everything else, I think healthcare is becoming more consumeristic, with services available independent of the provider. In genetics, you can get genetic testing without a physician. You can get total body MRIs without a doctor or a clinician. You can get multi-cancer early detection direct to consumer. And so my point here is that I think it's important to be cognizant of these trends because the practice of medicine is changing, and a lot of the historical insurance restrictions as such might be less relevant. And the last thing I just want to say is self-advocacy. So ultimately, I'm a big believer that the best thing that an individual can do is to be knowledgeable about their condition and their disease and to empower themselves accordingly. And part of empowering oneself is to have a good therapeutic relationship with one's provider. If that doesn't exist, I think getting another opinion is something that I would advise anyone to do. It's what I do when I'm not in a good relationship with my doctors. And ultimately, it comes down to patient preferences. What's most important to you is what's most important to you, and I think that's really what's important. So here's my bottom line. So I'll give you my bottom line up front for pancreatic cancer screening when everyone's still awake, and then we'll give you some detail, and then we'll circle back to this at the end. And so, if one is in a high-risk group, should they screen for pancreatic cancer? Okay, and in my mind, the answer is yes. I think the relative benefits outweigh the risks. It's what I would do personally, okay? What does high risk mean? High risk means those with a mutation and those without a mutation, but meet family history criteria that are consistent with CAPS guidelines. And we'll go over that in a sec. When should screening start? So for the majority of people, okay, this is going to be around age 50 or 10 years prior to the earliest onset of pancreatic cancer in the family. There are gene-specific and guideline-specific variations here, I have to say that. The modality, so endoscopic ultrasound and or MRI. Some people advocate blood tests, like a hemoglobin A1C, a glucose. Some people say CA19-9. My personal opinion is I'm a little bit less convinced of the utility of CA19-9. That's my opinion. How often? Yearly. In terms of emerging modalities, which we'll go into in detail, there are direct-to-consumer and research-based tests that are worth knowing about in this field. And the last point I just wanted to make in terms of the bottom line is lifestyle modifications should be a part of preventative strategies, and we'll talk about what that means. All right, so I think this is like the most important message up front. I think the overall concern about pancreatic cancer is reflected on the slide. And so the issue is that only 13% have localized disease on diagnosis. And prognosis is directly dependent on stage at presentation. So if you have localized disease, historically there was a 5-year survival of about 44%, but regional and distant disease have survivals of 16 and 2%. And so the time of diagnosis, the stage of diagnosis is really, really important here. And what's changed? So in the last year, a lot actually has come out. There was new observational data that came out from 2 studies in the Journal of Clinical Oncology. And Matt Yergelin from Harvard had a really nice commentary in JCO, which I think synthesized the main relevant points. And these are the best data we have, okay? And so there's 2 studies that you see here. Just a couple points I want to make. The individuals in the CLAT study on the top were CDKN2A carriers, and the population in the DBUK study on the bottom were a combination of individuals. with hereditary cancer mutations as well as familial pancreatic cancer. And these were all individuals who were undergoing some permutation of US and MRI examinations for pancreatic cancer screening. Okay, the most important points here, or the most important figures, I should say, are the ones that are circled. So for the CLAT study, what you see is a 5-year overall survival of 32-ish%. And for the Dubuque study, a 5-year overall survival of 73%. Okay, so those numbers are super important because you compare them to a historical 5-year overall survival of 11%. So this is a pretty amazing, it's a significant difference from historical estimations. One thing to say up front is I'm not sure why there are differences in overall survival between the two studies, the 32 and the 73%. It could be differences just in the overall sample size and the N of population that are here. Could be in differences in the conduct of the EUS or the MRIs that were done, or even the mutation-specific natural history here. I'm not sure, but it's just something that I wanted to point out. So some notes here. The first thing is that these studies, while great, are observational data. It's not randomized control trial data, okay? But the effect size was so large that it makes you think that the benefit was real. That change in 5-year survival from our historical measures is so significant, so big that you think, okay, this, very well could be true. The second is a discussion of something called lead time bias, which basically is, are you detecting something early just because you're looking for it and it actually doesn't confer a survival benefit compared to had you just, left things alone and things had presented symptomatically? Given the extent of benefit that those two studies showed, I think that's less likely. I think there probably is a significant benefit to screening, but I want to be transparent, okay? And the third thing which we have to say is that there were some cases of individuals in these studies who were undergoing annual screening and had no lesion detected on one exam, and then within a year had significant disease. And what to make of that, I'm not sure. I don't think it necessarily diminishes the overall positive results from those studies, but it's just something that's worth pointing out, okay? So who is at high risk for pancreatic cancer? One is those with a hereditary cancer syndrome, with a mutation. And keep in mind that the average risk for anybody off the street is 1 to 2%. And so even for the majority of the syndromes or the mutations that are listed here, even with an elevated risk, your overall risk is still pretty low, okay? The issue here really is that the recommendations for now, the guidelines state that only those with a family history should be screened, okay? Which I think is off base. I think what this is a reflection of is an incremental approach in medicine, and some historical convention, and some lack of data issues. Though there is data that we have, conversely, which show that 80 to 90% of those individuals with a hereditary cancer syndrome, with pancreatic cancer, do not have a family history. So I do think this is, I think a family history restriction is not appropriate, okay? Another group at risk of pancreatic cancer are those with a family history, as defined by consensus CAPS criteria, the most recent of which were published. This is expert opinion. It came out, I think, around 2020, and they're listed here. The bottom line really, I know it's a lot of text, but is that there's a minimum threshold of about having 2 affected relatives with pancreatic cancer on the same side of the family in the absence of a mutation, and that's what qualifies an individual for screening, okay? In terms of what modality to use, and so we're really talking about MRI versus endoscopic ultrasound. MRI, I think, is pretty straightforward. You might see a distinction between MRI and MRCP. And just to talk about the nomenclature for a sec, MRCP is magnetic retrograde cholangiopancreatography, basically. MRCP does not need contrast, and it basically just focuses on a visualization of the pancreatic ducts, okay? The MRI abdomen per se is what's done with contrast, and it visualizes the pancreatic parenchyma. It just, one looks at the ducts and the other one looks at the tissue, but just for nomenclature, it's worth making that clarification. Endoscopic ultrasound is upper endoscopy. It's upper endoscopy with a side viewing scope. It's basically, with a scope that has a camera on the side and an ultrasound probe at the end, basically. But it's the same idea as an upper endoscopy. To compare the tests, you'll see the first 4 bullet points here, and they're basically the same. And I mean, I think they're both good tests. They're both operator dependent, and what that means is, I think to some extent it does depend on who's reading the MR, who's doing the endoscopic ultrasound. Both take about half an hour, and both have incidental findings. With the MRI, if you kind of look at the bullets 5, 6, 7, there's no sedation needed. If a biopsy is needed, it cannot be done at the same time. And there is a potential just for claustrophobia, for just being in the machine. With EUS, if you look at the concurring bullets for 5, 6, 7 there, sedation is needed. If something is seen, biopsies or a fine needle aspiration is possible. And it's done at the same time as an upper endoscopy. And so if one needs an upper endoscopy for another reason, it's pretty easy just to piggyback the two. Not all gastroenterologists do EUS. It's something that's worth knowing. In our parlance, it tends to be the advanced endoscopists. It's specific people who have additional training to do so. So just something to note. Actual complications of EUS, they're pretty infrequent. I mean, they're very infrequent. And so I actually haven't even put them on the slide. For emerging modalities, so there are some direct-to-consumer products or tests, I should say, that can be obtained without a clinician's prescription. Whole body MRI is one, okay? What I note is that whole body MRI is not as sensitive for anything really as a dedicated MRI. So just be cautious in terms of the actual sensitivity of that test. I think another test that is worth being cognizant of is this notion of multi-cancer early detection. These are tests like GRAIL. Force has previously conducted a review on GRAIL that can be found at the link provided there that I listed. What I just wanted to point out was there's a study that just came out I think in the last week in Lancet, and that's what I highlighted here with some prelim data for GRAIL, about 6,000-ish patients. One thing to note is that the false positive rate for GRAIL was about 62%. Okay, we don't expect our screening test to be perfect by any means, and I'm not saying that this is necessarily a bad test, but it does open your eyes. It's 62% that came back positive. So again, I think Force has done a really nice job addressing the multi-cancer early detection assays, and so this is just more up-to-date information. On the right-hand side of the slide, you'll see there are research-based protocols that can be found as well. And so per my calculation, there's about 21 trials that are actively recruiting currently in this space of pancreatic cancer screening. Those trials can be found on the Force website or at clinicaltrials.gov, easily accessed website. So some outstanding issues. Access to care. The majority of the guidelines say that these are tests that should be done in expert academic centers, okay? We do know in medicine that for the majority of things, the majority of outcomes, there is a correlation between expertise and outcomes. There just is. The issue, quite frankly, is that it's not realistic for the majority of the US population to get their care at academic centers. And I just don't have an answer for that, unfortunately. Two is the family history point that I mentioned earlier, limiting screening to those with family history. To me, that doesn't make sense. I can tell you in practice, we are often able to get our imaging covered or our endoscopic ultrasound covered for those without a pancreatic cancer family history, who are mutation positive or who meet other clinical criteria. I don't know if that's specific to our geography or to our institution, but worth mentioning. What about other mutations than the ones listed? What about CHEK2? What about BRIP1? And so this is challenging because, again, I think there's a lot we know, and I think there's more that we don't. Our understanding of genotype-phenotype relationships is changing annually. And I think if you look in the literature, you're always going to find a paper that says, you know, a certain mutation was found in an individual with pancreatic cancer, but association does not imply causation. So what you need are really large studies with a ton of people that show some sort of increased statistical risk, implying causation. I also think what I do in clinical practice is I think one can look intellectually at certain genes and the functional role they play, especially compared to other genes like BRCA1/2, and make inferences as to their potential for being a risk factor. And so what I do is I use that, I look at family history, I look and see if the gene segregates in a family with certain individuals with pancreatic cancer. And then if I do feel strongly, and if the patient feels strongly as well, we might collectively advocate for screening. Sometimes we're successful with insurance, sometimes we're not. But again, this is our practice. One thing I should have said, which I don't see on the slide, but I meant to mention, was incidental lesions. So if you look, you're often going to find stuff. That's just how it works. The diagnostic yield when one does pancreatic cancer screening for anything, you know, for finding a cyst, for finding something unanticipated, the data is all over the place. Okay, so it's between 5 to 70%, and so clearly huge range. What I'll say is this, okay, the majority of cystic lesions in the pancreas are not a big deal. They're benign and they'll stay that way. Frankly, if they are going to convert to something, and this is my opinion, it's better that they be found early and that we are able to follow them sequentially so that they can be surgically removed if the time comes. But that's my take on incidental lesions, and kind of, again, emphasizing the whole risk-benefit scenario. So last point on this slide is this: lifestyle modifications. And I think these are really important too. You know, I don't think of genetic predisposition as fate or destiny. That's just not how it is. Generally speaking, what we say is the stuff, you already know the stuff. So tobacco is bad. You know, I think there's a pretty clear association of alcohol with cancer development, and I think it is a linear relationship. So I think 0 is better than 1 drink, which is better than 2 drinks. Sugar, red meat, saturated fats are likely carcinogenic. But, you know, I think my take is this. I mean, I think you want to be happy and you want to live your life. And so if you want to have a drink, have a drink. If you want to have a steak, have a steak. If you want to have a cake, have some cake. You know, just be mindful. That's kind of my approach here. Okay. But I think this stuff is important as well, for the environmental modifiers. So going back to my summary slide, should I screen for pancreatic cancer? Yes, I think if you're in a high risk group with the recent data, I think it's absolutely appropriate. Again, the age around 50 or 10 years younger, there's variations in the guidelines and these things change quite frequently. So worth knowing the modalities we talked about. And there is no set modality, to be honest. Endoscopic ultrasound and MRI are both good tests. There's, for each guideline that's written, there's a different recommendation. My personal take is do something. I think that's better than doing nothing. How often? I do think annual makes sense. The emerging modalities we talked about and the lifestyle modifications as well. It's a pretty pithy overview of pancreatic cancer screening. This is who we are. We're in the city. This is our genetics and cancer prevention program. For those of you who are local, we're always happy to serve as a resource. And that's it. Thanks.
Excellent. Thank you, Dr. Phillips. So we're going to come on. You actually did a wonderful job of answering most of our questions that were submitted by our audience members prior to tonight in the presentation. So I thank you very much for doing that and tailoring the presentation that way. But we did have a couple more that did come through that I would like to address. And so this first question comes from a constituent who's starting at kind of the beginning of this journey. And so they do have a family history, but they have not undergone genetic testing. And they're wondering what type of doctor should they start speaking to first about monitoring their risk?
That's a great question. So it's an individual with a family history of pancreatic cancer?
Correct.
Is that correct? Okay. To be transparent, okay, hopefully the first step will be the right step, but sometimes it may not be, okay? You can certainly start with a gastroenterologist, and the specific statement I would make is, I have a family history of pancreatic cancer, which by most guidelines meets criteria for germline predisposition testing, something I'd like to pursue. I'd also like to know if my family meets CAPS, C-A-P-S criteria for pancreatic cancer screening. That would be my first step. See how that goes, okay? If that doesn't go well, or if you feel like, the provider may not be versed in this field, then I think seeing somebody in genetics, and so that means somebody who does cancer genetics. And so it can be a genetic counselor, it can be a medical oncologist, it can be a gastroenterologist, a medical geneticist, but finding a cancer genetics specific service, hopefully that's helpful. But I think that's, in my mind, the kind of tiers I would go through.
Okay, excellent. And so in terms of then, once you're further down the road and you're going through screening, there's a lot of audience members who are interested to know if you foresee a time when regular pancreatic screening becomes something that is standard, in relationship to getting a colonoscopy. Do you see the medical field moving that way with these recommendations?
That's so for people who are average risk and not at high risk?
Correct.
The short story is yes. The short answer is yes. I think in cancer screening, diagnosis, treatment, every day currently is evolutionary, if not revolutionary. And so it's a pretty remarkable time to be alive. GRAIL and the multi-cancer early detection test, while perhaps while they're in development, I think are a sign of things to come. And having these assays that are easy, that are blood-based, that eventually will be high sensitivity, either as an adjunct to what we're currently doing, or maybe even supplementing. And eventually with scale, cost comes down tremendously as well. So yeah, unequivocally, I think that's the future. Yes, yeah, absolutely. It's just, it's the technology which is developing, and it's the costs which decrease basically daily.
Okay, thank you. And so, and talking about, the type of blood tests that are available to constituents evolving, if we could take a step back from there, and if you could just speak a little bit more about the CA19-9 and what it's testing, and what it looks at.
Yeah, so CA19-9 is interesting. And so it's a test that has been utilized for cancer recurrence, okay? Not a new diagnosis, but recurrence. It can go up in various conditions, okay? So it's not necessarily just pancreas or biliary or liver conditions, okay? And so someone can have a gallstone, and someone can have an obstruction of their common bile duct, and that can elevate their CA19-9. Someone can have a tumor, and that can elevate their CA19-9. Other people just have slightly elevated CA19-9s, and nothing's going on. So it's tough. It's been used, its approved use is for cancer recurrence, okay? Using it as a primary screen is a bit dicey because it wasn't intended for that, and it's not sensitive for that, and you can get false positives. So that's why my personal opinion is it often causes more harm than good, because to me, a positive CA19-9 doesn't, or an elevated one doesn't necessarily mean something's going on. I think of the blood-based tests, if we're talking about pancreas cancer development, the A1C I can get more behind, and the glucose is basically it's along the same lines. It's looking for new onset diabetes, which can predate the development of pancreatic adenocarcinoma. So hopefully that's helpful.
Yes, that is helpful. And actually, so now I'm trying to decide which question I want to ask next, because you touched on two things. So I'm going to take it this direction first, which is this constituent is worried about concerns and the risks that come with screening. So specifically speaking to exposure to MRI contrast agents, can you speak to a little bit of that?
Great question. It's a great question. Here's what I'll say. So MRI, first thing, and I think the constituent knows this, but there's no radiation, number one, okay? Number two, for the contrast. So in our current day, there's a lot of medical leagues I'm about to use. So in our current, to our current knowledge, okay, with the current contrast we use, there's no known adverse effects, okay? Historically, there was kidney toxicity and a corresponding syndrome that was associated with MRI contrast. This is about a decade ago, okay? That contrast is no longer used. And if there are concerns, I'd ask the radiologist, because, and they'll tell you transparently. So that's one. Historical issues with kidney function and an associated sclerosis that are no longer a concern. Number two is there is some contrast accumulation in the body. There just is. That's 100% true. We don't have any data right now linking that to adverse effects. So that's our current status.
Okay, excellent. And so then I'm going to go back to another thing that you said in the previous question when you were talking about insulin levels. This constituent wants to know if co-occurring diseases like Crohn's or diabetes increase your risk for developing pancreatic cancer, or if they would have to be unrelated and your risk would be more tied to family history or genetic mutation.
It's a good question, and I'll tell you what I know and what I don't know, to be honest. So Crohn's, no, there's no association. New onset diabetes is a risk. Honestly, I need to look up. I don't know if longstanding type 2 is a risk for pancreas. If there's potentially a chronic pancreatitic state, yeah, that's a risk. I'm sorry, and tell me the second half of the question. Or
just if co-occurring diseases can increase your risk for pancreatic cancer.
Or family history. The main things is, so again, average risk is like 1 to 2% per year, and so that's anyone off the street. The main risk factors we think about are the family history as defined by CAPS criteria, mutation positives, people with chronic pancreatitis. There are some environmental factors too, tobacco, ETOH, all the usual stuff. This is for adenocarcinoma, I should say, and because there are different types of pancreatic cancer, but we're talking about adenocarcinoma. So those are the main risk factors.
Okay, thank you. And so, and just more in terms of managing risk, you had said in your presentation, the best place to be is, to be doing your screening or under care is at an academic center. But we have a lot of constituents that live all across the country,
Yeah.
some rural areas, some in suburban areas. So
Yes.
for those constituents who aren't necessarily near major medical centers, what can they do to ensure that their providers are staying up on the most current or up-to-date standards of care? What can they do themselves to advocate for themselves, like you said when you began this presentation?
Yeah, no, that's a great question, and I'll try to answer. It's yeah. I'll tell you what I know or what I think. I think we have to meet people where they are. We have to, not everyone can fly to New York or fly to whatever, Boston to get their care. That's crazy. For personal advocacy, this is what I'll say, okay? And so force. So force is a great example of the ability for personal advocacy, because one can be, what you really want is to be up to date with the medical literature and kind of the current evidence. That first and foremost that's the most important thing, and that can happen through patient advocacy groups. One other way is the medical literature, and so or clinical practice guidelines. And so NCCN, for example, which most people take as the standard, I believe is accessible to anybody. I think there's a login which needs to happen, but once someone logs in, I think the guidelines are downloadable. And so it's a link, it's an NCCN, hereditary breast and ovarian cancer, or hereditary breast and I think pancreas is the name of the document now. And so those are the most up-to-date guidelines that change every 6 months. So it is, dense, certainly, but it is what it is, and like that's what the recommendations are currently. And so that's one way. Another thought is, and what I say this with humility, what I'm about to say, but for the 2 papers that came out in JCO, in the Journal of Clinical Oncology last year, those are Googleable. And so if one Googles pancreatic cancer screening, JCO 2022, these 2 papers will come up, and the PDFs will come up too, okay? If a provider doesn't get it, or is like, oh, I don't know what's going on, sometimes it's, okay, here are 2 PDFs, do you mind eyeballing these for me, please? And because that's the data, and there's an editorial, actually even easier, that's associated with those papers, that even if someone is busy, and people are busy, that even summarizes the findings and how they should be practice changing. So, sometimes you kind of need to manage up. The other thing, and this may or may not be feasible, is there are guidelines for, there are subscription services. And I'm not saying that everyone should be doing this, but there's entities like UpToDate, okay, UpToDate, oneword.com. It is an expert opinion based resource for medicine, for anything medical. Okay, so physicians will use it often. My dad, who happened, when he was still living, happened to be very a strong self-advocate, I should say, really wanted to know what exactly was going on with his medical care. And so I said, okay, Dad, get up to date and look it up, and then talk to your providers. And that's what he did. And then he knew more than his physicians about a lot of stuff. And so, up to date is this, there's no financial link whatsoever, but I'm saying, services like that can also be accessed through libraries. I'm trying to get at reputable sources that one can go to get more information. And so bottom line is, Force, I think, is a great resource. Sometimes pulling the literature. Google can be a resource, so it's one you got to be a little bit cautious about, given all the stuff that's on the internet and the reliability of the data. Expertly curated sources like UpToDate are another. So that's a long answer.
Excellent. I think those are all really good resources. Specific to Force, we do have our X-ray program, which takes headlines and articles, like you said, PDFs that are out there, and we'll fact check them for you so that constituents don't have to try to wade through that alone. So that's a great tool if you've never used or visited our X-ray tool. It's right on our website here with Force. You did mention something about your dad, and we did just have something come up in the chat asking to kind of create more or just speak to what the actual parameters of are when we talk about defining family history. Is that immediate family? Does that include uncles, extended family? How far does family history actually take us?
So are these slides going to be distributed too or posted?
They'll be, so everything is recorded tonight, and then everything will go onto our website so everybody can review.
Amazing, amazing. So so check out the slide with the CAPS criteria, because that basically delineates specifically what family history criteria means. Generally speaking, the most agreed upon criteria are the individual who is considering pancreatic cancer screening should be a first-degree relative of another individual with pancreatic cancer, and there should be 2 other individuals with pancreatic cancer on that side of the family. Okay, so it's 3 individuals, and there is a first-degree relation between at least 2 of those. Some of the less stringent criteria are 2 people on the same side of the family. There's variation here, again, per guidelines. Close family relative depends on who you read. Some people define it as 3 degrees, and other people define it as 2. But check out the CAPS criteria, because that's the most specific, and I think that'll answer the question.
Okay, excellent, thank you. And then for our last question here tonight, we just have a constituent who's asking specifically, what are the most common symptoms of pancreatic cancer? What should people be looking for, even if they are screening?
It's tough. Pancreatic cancer is tough because oftentimes, not always, oftentimes when one is having symptoms, it's advanced. The pancreas works to what basically happens is if there's a mass in the pancreas, pain can be a symptom. By the time people are having pain, it's often advanced disease. It's pain that's it's epigastric. I'm kind of pointing right above my belly button, below my rib cage, and it goes straight back. So it kind of radiates to the back. That's what we say. That type of pain could be a sign. There's a ton of other conditions that cause the same symptoms, so I don't want one to think that's the only possible diagnosis. The other thing is the classic sign is painless jaundice, and so there is no pain. There's a mass in the head of the pancreas, and it blocks the outflow of bilirubin, and so then people get jaundiced. And so that's the other classic sign symptom. Because the symptom signs only present late in an individual with risk, screening is the way to go.
Okay. Thank you very much for driving home that point. I think you covered a lot of ground this evening, and really we got to mostly everybody's questions. So thank you so much for giving us your time here tonight. So that will conclude your portion of the presentation. And at this time, we are just going to quickly just close out. We'd like to thank our sponsors again for helping to bring this programming to you. As Dr. Sharaf asked earlier, this presentation, of course, is going to be recorded. We will upload it to our website for you to go back and review, to share with your relatives. It will be available to you on our website underneath our webinar section. So please make sure to revisit that. And please continue to reach out to Force for your support and information needs. Remember, while there are many mutations and many cancers, there's just one community, and that is the FORCE community, and it is here to support anyone who is impacted by them. So thank you very much for attending, and good night, everyone.